the favor of being a public figure has come through for me, but not many people have that access. And people in power need to know that it is your responsibility, so that people I don't need to know people at SHA. It should work without me knowing people.
The Social Health Authority, SHA, is here. But is it living up to its promise? Let's find out. The rollout of the Social Health Authority, SHA, sparked promises of universal healthcare, stirring hope for millions of Kenyans. But as the dust settles, a critical question emerges. Is SHA living up to its promise, or are cracks in the system leaving vulnerable patients behind? We dive into the stories of those navigating this new system, particularly dialysis patients whose lives depend on consistent care. Fred Karumba, widely known as DJ Krowbar, is a celebrated Kenyan DJ, media personality, and sound designer. Known for his innovative approach to music, he seamlessly fuses African rhythms with cinematic elements in his performances. But recently, he found himself in a different kind of spotlight while advocating for his wife's health and well-being.
There was a law known as SHA, Social Health Authority, and that law was taken to court, and unfortunately the government won. So when it won, we were all told to register. So people who are employed were by default converted by their employers from NHIF to SHA by default. So you didn't need to do anything. And on the flip side, whatever we were paying increased. Yes. Actually, we used to pay 1,700. Now mine has really increased because it's now 2.75% of my salary. And out of that, we have been adjusting since. So when I was converted, you had to add your dependents by yourself. So I added my wife, I added my 3 kids into my SHA cover. And then after that, it was like it changed to like on a Friday, and on Monday my wife was doing dialysis. And I remember it was a huge nightmare. My wife got a phone call from her dialysis center, and she was told, starting next week when you come, you have to pay cash because we don't have an MOU or a contract with SHA. And so because of that, you have to pay, as we have a contract with NHIF. And so that evening, when that phone call was made, she was very devastated. And I remember I was seated there, we talked, and I remember I called some of the, when your wife is on dialysis, you get to deal with the government medical cover a lot, because sometimes it's reflecting, sometimes it's not reflecting. So you have to do those follow-ups. So I called my contact then, and I asked him, hey, so what's happening here? Is it going to go? And then he advised me, you guys just go in the morning. If it doesn't, you call. And then I went like, we can't do that, because we are not sure of what will transpire. And so what happened was, after that phone call, then I decided to record a video of where I was. And so I recorded that video and I posted it. I know some of the people in charge of this might watch this video. The Ministry of Health, I'm sure maybe the CS might watch this. The leadership at NHIF, now anajiita SHA. I hope you guys get to watch this. I want you guys to understand. Literally, it's like you have like 24 hours to really do some solid communication nationwide, because lives are at risk here. Lives are at risk. And so after I posted it, it ended up going viral. And I remember 2 hours or 3 hours later, I got a phone call. I got a phone call from a gentleman who is in the Presidential Health Advisory Committee. And I remember he called me and he said, "What's the situation?" And I told him, "This is the situation, so we've been called." And I gave him context, and he said, "You guys go, and then you will tell me how it unfolds." And so the following morning we went. So when we went, we found out that the guys who already plugged in onto the machines had actually paid. And the reason they had to pay was because if you don't do dialysis for a week, you get a lot of creatinine and you just might die in 2 weeks. You unaenda because that's too much dirt in your system. And so out of the fear of their lives, some people paid, now cancer dialysis. And so when we got there, we were told, "Hey, you guys have to pay. You have to pay." And so I called that guy and I told him, "So we are the center and we have been told to pay." And he said, do you have the contacts of the owners of the center?" And so I knew Momanyi, and so out of that, they were able, a couple of phone calls were made, and they were told to go straight to SHA offices at Westlands and pick their MOU and or their contract. And they rushed to SHA offices, they picked their documentation, and immediately they picked, we were logged in. And I remember a few days later, Mo telling us, if it wasn't for you making that noise, we would have never gotten the contract. I'm happy. I really am. So, tuendelee. I hope at the end of the day, as many facilities get their MOUs, and not to get treated, man. Not to get treated. So, right? A win is a win, man.
To gain more insight, we visited NephroMed, a dialysis center in Nairobi, to understand their experience transitioning from NHIF to SHA.
Our facility, NephroMed in Nairobi, has signed the manual contract, which was issued to us on 30th of September. So on the 1st or 2nd of October, we signed and returned it back to them. Post that, there was an e-contract. So initially, there was first 10 days or so, there were some certain challenges, but I think we are now have overcome, and both our facilities are now on the e-contracting. Right now, the situation is that NHIF has old payments have come in very small part. So it is a positive sign. Whether it's a good beginning or not, I cannot comment right now. But as far as SHA is concerned, our payment has been coming every 2 weeks to 20 days. Again in bits and pieces. So our humble request would be that if SHA is paying us, and SHA is paying us in certain amounts, they should pay us first in, first out, so that we'll be able to also reconcile easily and give them a correct picture on a monthly basis of what is due. So it will help them, and it will help us also as an institution.
To confirm this, we meet Steve, a dialysis patient at NephroMed who attends 2 dialysis sessions per week.
Kwa sasa siwezi sema ati kuna tofauti juu kila kitu naona tu inaenda tu the same na NHIF. Malipo ndio sijaanza kulipa, cause NHIF nilipa 1 year. Sijajua inalipwa aje, but kuregister ni register.
While SHA aims to streamline healthcare access, it comes with downsides for dialysis patients, especially those who require more than 2 sessions a week.
Now, for dialysis patients, you're given 2 sessions a week maximum. My wife does 2 dialysis sessions, but there are patients who have 3 sessions. So patients who have 3 sessions a week are patients with 0% kidney functioning. So people who do dialysis are people who are 15% and below. So some people are 11%, 10, 7, 5, like that. So usually anything between 5 and 15, you do 2 sessions a week. But those people who are at 0% functioning, they need 3. So SHA only covers 2. If you're doing 3, the third one you pay cash. They're paying cash now. Under NHIF, if the patient had their own cover, NHIF would pay 2 under your cover. If I was the spouse and they were doing 3, my cover would pay the third one. So they wouldn't pay. But under SHA, that can't happen. The third one you pay cash.
With SHA, we have, in last 3 months, we have not experienced any patient requiring 3 dialysis. So, and I think there is a provision with SHA. We will cross the bridge when we'll reach the bridge in that case. So let us have a couple of patients and then we will see what kind of hurdles do we have, or is it so smooth. But as far as regular dialysis patients are concerned, the process has come to a streamlined process for now. It has improved from the first 15 days to 20 days because still for the first 10 days we registered SHA patients manually also. And we have submitted all that data once they have asked from us to submit all the claims, manual claims, which has already been given to them.
Do we need more training to understand how SHA works?
This transition is happening. I think we all need more in-depth training and in-depth knowledge about how the SHA will function in such cases. And I'm sure these are one of the FAQs which I keep seeing moving around in various groups, that since this provision is not there, how do we handle it? But as I again said, with a clear clinical explanation of why a certain client need third dialysis, I'm sure SHA will approve. And if the beneficiary is not covered for that, then they obviously pay out of pocket.
Now, for dialysis patients, you see that is a routine system. So for dialysis patients, it is working for them. So they go to a dialysis center. You know, there are different tabs for different types of treatments. And so for dialysis, it has never failed. And even if the system is down, they will still do dialysis. And then they will later on do re-updating. But the way SHA is supposed to work, it's like this. That woman who gave birth and went into the presser, the Ministry of Health presser, and they complained. So you are supposed to go, if you are covered, and be treated without questions. Then they follow up with SHA. That's how it's supposed to be. But hospitals, because it's a business, they follow up first before they treat you. And you should be treated. It's your right for you to be. Literally in Kenya, universal health is a right under SHA, and you should be treated. But because the hospitals are trying to protect their bottom line, they confirm first. And if the system is down, they say, we can't touch you.
Could the SHA rollout have been done differently?
How do I think they should have rolled out? They should have rolled out SHA in phases. The Kenyan medical system, we go from level 1 to level 6. Level 6 is a referral center like Kenyatta, okay? And then there are level 5 hospitals, level 4 hospitals. So 4, 5, 6 are all hospitals. Then 3 and 2 are dispensaries, and then 1 is clinics. Umenishika. So they should have chosen out a system between that on how to roll out. or they should have rolled out in phases of, let's do people who are doing surgeries. Let's roll out surgeries and people who are doing chemo and dialysis. Or let's roll out outpatients. Or let's, and I'm not saying they roll out chemo and therapy for a week. No, they roll out chemo and therapy day 1. Day 2, we roll out outpatients. Day 3, so that people know within a week, this is the system. But they didn't have a system like that. Then they just opened the taps and whatever happened, happened. It is, unfortunately, in this process, people lost their lives. Unfortunately, people have died out of this rollout. And there are people mourning now. Who will take blame for this? Ownership? I don't know. That's a huge lawsuit if people ever choose to pursue that route to sue the government.
Was it implemented too hastily? And what about the voiceless patients who struggle to make their concerns heard?
In my own opinion, us moving from NHIF to SHA was not an emergency. For real, it was not an emergency. I think it's purely political. On the back end, so funny. The system NHIF used to use, the ICT system that they were using, was owned by a politician. So NHIF used to pay that person a lot of, because it's his system. They're using his system to run health in the country. Umenishika. And because there is no political goodwill, so it needed to change from NHIF to SHA. Umenishika. And that's why it was pushed very quickly. Other than that, it wasn't an emergency at all. The favor of being a public figure has come through for me. But not many people have that access. And people in power need to know that it is your responsibility, so that people I don't need to know people at SHA. It should work without me knowing people. Aki, for real. It should work without me knowing people. Unelewa? And that's the dream. That's the dream. But unfortunately, that's where we are.
As the Kenyan government, through its leadership, calls on citizens to keep enrolling for SHA, so far, over 18.5 million Kenyans have enrolled, out of which 14.6 million are principal members and 3.9 million are dependents. About 8,000 health facilities are contracted with SHA, and over 9.8 billion Kenya shillings has been paid out in claims to these hospitals since SHA started on October 1st.